Hey everybody, welcome back to Summit Healthcare Education. Today we're going to be doing the basics of EKG interpretation, not getting into any rhythms or anything crazy, but it's a good starting spot. So if you're interested in the topic, follow me and let's get into it. Okay, so let's get into it. Basic EKG interpretation. So we're not going to be getting into what is this rhythm, what is that rhythm. We're going to break it down to a little bit more of the nitty-gritty here. So first things first, let's move down to our 4-lead EKG. Now, a common misconception is that the EKG is the full 12 pictures of the heart. When you look at it, if you have any understanding of what like a heart attack would look like, that's what we would use to identify this. We're talking about just the rhythm. How is the heart doing? Is it going too fast? Is it going too slow? Is the rhythm abnormal? Is there anything weird kind of going on with that? And that all starts with our 4-lead placement. Now you may hear people call it the 3-lead placement, and that comes down to just kind of the as we call Einthoven's triangle, which is the right image here with the gentleman with his arms out. But regardless, they do the same thing, right? The 4 and the 3-lead. They are giving us the general rhythm of how the heart is doing. So let's just start with those leads. There are going to be 4 of them. There's RL, RA, LA, and LL. Okay, so right leg, right arm, left leg, left arm. Now you'll also notice that they're color-coded. That right leg is green, right arm is white, left arm is black, left leg is red. And so a very common kind of mnemonic that a lot of people will use is clouds over grass, smoke over fire. Okay, so based on just the letters, you should kind of have an inkling of where they should go, right? LA is going to be the left arm, RA is going to be the right arm, right leg, left leg. Now, there's some back and forth about where you should put them. I've seen people put them on the wrists and the ankles, and that works just fine. However, anytime that patient will move, that rhythm is going to have what we call artifact, or it's going to look just kind of like a more aggressive squiggly line, which makes it really hard to read. So, preferred methods, keep it on the trunk, right? If I'm a hand talker and I have it on my wrist and I'm doing this and it's on my, or excuse me, I have them on my trunk and I'm moving my arms, it's not really going to affect the rhythm as bad depending on the motion. So a lot of it is going to be shoulders and then the lower portions of the abdomen. Like I said, you can do arms and wrists, but you're really banking on that patient not moving. Now, what we're really asking with that is just keep it consistent, okay? If you're going to put it on the trunk, keep it on the trunk. If you're going to put it on the wrist, put it on the ankles. But ideally, it's trunk, get access to skin, because you will be putting these little electrodes onto the skin directly, which will line up, or excuse me, link up with your monitor, in which case you'll start seeing the little stripies start showing up. So, scrolling down, we've talked about the leads. Let's talk about the paper. Now the paper is pretty specific. If you look at EKG paper, it's made up of a bunch of teeny tiny little boxes. Each one of these boxes actually represents a segment of time. Now, we're going to be referring to them in seconds. It's not uncommon for them to be referred to in milliseconds just because of the unit transcription there. But the smallest box, the teeniest tiny little box, which I have here in purple on my screen, is going to be worth, is 1 millimeter. So each one of these tiny boxes is a total of 1 millimeter in width. But that's going to be 0.04 seconds, okay? Or 40 milliseconds if we want to go there. But 0.04 seconds. Now we group these 1 millimeter boxes into 5 millimeter groups. So five little boxes, okay? So when you get that grand total, 5 little boxes, you're going to have around 0.2 seconds per bigger square, or that conglomeration of the 5x5 boxes there. Now, we'll talk about this later, but it's important to know that when we read a strip, we need a minimum of 6 seconds. 6 seconds helps us to really truly identify that rhythm accurately. So keep in mind, 30 big boxes, 30 of the bigger conglomeration boxes, is a total of 6 seconds, which we will come back to here in a moment. Okay, so scrolling down, let's talk about our squiggly lines here. Now, I will be coming back to this image, so you'll see that as I come back and forth, but let's start at first with the baseline. The baseline is also known as the isoelectric line, okay? What that really indicates is going to be the space between heartbeats. Okay, now remember, this whole thing is electrically based. We're gearing this on the electrical activity of the heart, not necessarily the mechanical activity of the heart. This is where lining up a pulse to a QRS complex or to a heartbeat on the EKG paper is going to be important, because there are rhythms where we don't have pulses and they still have some electrical activity moving. Okay, but like I said, that isoelectric line, that baseline, that's going to be that spot in between heartbeats where there's no cardiac activity electrically happening at that time. And like I said, I'll come back to this image. I think this image does a good job. Now, let's talk about the deflections. Now, each one of these little bumps on that line, each one of those little squiggles, represents something different. Okay, now if we think about how the heart itself actually functions, right? The atria contract, the ventricles contract. Remember, it's going to be bilateral at that point. So atria, ventricle, the whole point is to push blood into the atria, from the atria to the ventricle to the body, and with each heartbeat, the cycle continues. So we're constantly reoxygenating our hemoglobin in our blood. So the first little deflection, let's talk about, is the P wave, okay? The P wave, going back to that first image, if we're reading that from left to right, is the very first bump you'll see, once again from left to right. The P wave represents what we call atrial depolarization, which is just a fancy way of saying atrial contraction, right? The molecules in the cells are moving well enough to create an electrical spark to cause a stimulus that causes contraction. Okay, so that P wave is going to be, once again, that depolarization or the contraction of the atria. Now, as we move down, you'll see what's called a QRS complex. Now, the QRS complex is what most people kind of think about when they look at these 4-lead identifying EKGs, and that's the big spiky thing, okay? But that part represents ventricular depolarization. Now, one other point I want to talk about in here. When something depolarizes, it contracts. By extension, it needs to repolarize or reopen back up, okay? And we'll talk about that here a little bit further, but going back up, that QRS complex, we don't see atrial repolarization because it's happening at the same time as ventricular depolarization. So it kind of gets buried along that amplitude there, that electrical spike. So just know, when you see that QRS complex, that's not just the ventricle contracting, it's also the point that the atria is kind of relaxing and getting back to functional form, okay? Now, you'll notice on this slide here that I included a bunch of different, what we call morphologies or appearances of these QRS complexes. Not everybody's is going to be the same, and there are some that can be more malignant, there are some that are benign. But just understand that the standard QRS complex in a healthy person tends to look similar, but they're not always going to be the exact same. So this is just a little example there. So if you would like, take a pause, look at the video, or excuse me, look at that picture in the slideshow there. Now the last wave I want to talk about, so kind of rehashing here, furthest to the left is going to be our P wave. The big spike is that QRS complex that's also going to have the atrial repolarization or opening up in. The last bump there, so little bump, big bump, and then the last small bump is what's known as the T wave. The T wave represents ventricular depolarization, okay, or excuse me, repolarization, misspoke there. That's going to be the part where the ventricles relax, but because the ventricles are so much bigger than the atria, there is going to be some electrical activity going on with that, so we can actually register that, okay? And then there are going to be what we call intervals and segments there, and I will get to those here in a moment. So from the top, P wave is atrial depolarization, the first one on the left. QRS complex, the biggest spike, the middle guy there, that's going to be our ventricular depolarization as well as the atrial repolarization. And the last wave, the T wave, the one on the furthest on the right per complex, is going to be the ventricular repolarization. Now, this is just going to be the general, this is how most of us are going to read these complexes. And if you think about it, this is the heartbeat, okay? So each one of these represents a full cycle of contraction. Atrioventricle, relax. Atrioventricle, relax, okay? With that relaxing point, once again, being the baseline. Now, let's talk about methods in which we read these, okay? Now, there's a 5-step method, especially, we're not going to get into the rhythms today, but there are different things that we look at just to see, is this healthy, is this good, or is this bad, right? And those 5 steps are going to be the rhythm, the rate, the P waves, the PRI, which I'll touch on in a moment, and QRS complexes. Okay, so let's start with the rhythm. Is it regular or is it irregular? A regular rhythm will be in similar portions, or let me rephrase that, will be equidistant apart as they go down that paper. And you can use the lines on those paper to kind of tell you, okay, so for example, looking at this one, there's 4 boxes in between here. That's going to be a regular. If every rhythm that I'm seeing, or excuse me, every complex I'm seeing on that 6-second strip is 4 boxes apart, that's going to be a regular rhythm. Okay, now let's say I have 4 of them are going to be 4 boxes apart, but then we have one that's 2 boxes apart, and then we're back to 4 boxes. That would be an irregular rhythm because it's not consistent. We're looking for a same cadence every single time. Okay, going back down, the next thing we like to look at is our rate. Now, you need to have a little background knowledge, which if you're going to be going into paramedic school where you're going to be learning this stuff, or any scope of practice where you're learning EKG, you should kind of know the baseline normal human heart rate anywhere from 60 to 100. Okay? Too slow, slower than 60, bradycardia can be problematic. Too fast, north of 100, tachycardia can be a problem. Now, within reason. Okay, there are people, for example, a good example would be Lance Armstrong, right? He was in such good cardiac shape that his resting heart rate was well below 60. That there's nothing necessarily wrong with his heart at that point. It was just so efficient and effective, it didn't need to be at the 60 point. So he would be a case of a non-problematic bradycardia, and that would be at rest. Same thing kind of goes for our tachycardia. If someone's at 110, maybe even 120, but they just got done exercising, they did something stringent, maybe it's me sitting up off the couch, right? I'm going to hit 120 every time. Just things to consider, right? Not every time it goes north of that normal, or excuse me, goes past those normal boundaries is going to be problematic, but it is something that we need to at least pay attention to so we can identify, okay? So that rate, so like I was saying, if we do a 6-second strip, that kind of tells us that we can do some easy math and figure out what their minute or heartbeat per minute is going to be, right? If I have a 6-second strip and I have a total of 7 different QRS complexes on that strip, well, if I know 6 times 10 is going to be 60, that equals our minute. 7 times 10 would be 70, that's my rate, 70 beats per minute, right? So that's one method that a lot of people like to use. It tends to be pretty efficient. I will also say, when you're out in the field and actually operating, it's not uncommon for these strips to go further than 6 seconds. So you got to find those intervals, which kind of leads me to the second method that a lot of people will use. I personally prefer this method, but it's called the 300 method. So I'm going to scroll back to our QRS complex image here. So each one of those big boxes containing the 5 total millimeters of the tiny boxes, those, based on how far apart those QRS complexes are, can tell us something. Now this is a good image because the QRS complexes, they land right on a bold line. So this kind of tells us where we're already going to be. Now, let's say we had the QRS complex we see here on the left, and then the next one is directly on that next bolded harsh line. Well, that would be a rate of 300. Okay, that's going to be a total heartbeat for a minute of 300. If you're hitting that line every single time based on the time on the strip, that would be our rate. Now, from 300, let's say they're 2 big boxes away on the same bolded line. That would be a rate of 150, okay, because we're cutting that down in half, once again, based on the time. From 150, if it's on 3 boxes away on the bold line, we're at 100. Pushing it back to 4 boxes, we'd be at 75, which this is a good indicator. This picture exactly shows 75 beats per minute based on the 300 box method. Okay, now so it does go past that as well. So if we're 5 boxes away, that's 60. If we're 7 boxes away, it's 50. And that's usually where people will start to identify, seasoned provider of, okay, fast, slow. If I'm seeing a total of 4 complexes on my strip, I can assume things are probably not going nearly as fast as they want. But typically what we look for, 300, 150, 100, 75, 60, 50, 40, 30. And that's just as those move big boxes away, right? So complex stays, 300, 150, 100, 75, 60, 50, 40, 30, okay? Once again, when you're doing this, look for the complexes. Like I said, those strips get long, but look for the complexes that lie on those big lines, because if they're going fast enough, likely is one of them will. Okay, it's a really good identifier, and it's kind of a quick down and dirty way to get an answer you need if you just have to find an answer quickly, right? You're not going to go spend the time counting the boxes necessarily. Okay, so we got our rhythm, regular or irregular. We have our rate, fast or slow, north of 100, south of 60. The next one is P waves. Now, in particular, is there a P wave per QRS complex? We want a healthy human heart is going to be functioning top to bottom, atrioventricle. So we want each QRS complex to have a P wave before it, and a T wave for that matter, but we want to have that before it every single complex. That will help it to line up. Okay, that's how we can identify normal or not normal. Now the next thing, the PRI, or the PR interval. All that's referring to is the space in between the P wave, the first bump, and that QRS complex, okay? Now usually we like this to be at a fairly normal time frame. This is going to be, for the normal range, anywhere from 0.12 to 0.2 seconds, right? Or if we wanted to get, once again, to milliseconds, 120 to 200 milliseconds if you're going to move that decimal around. Okay, but we need consistency on that. We want there to be enough time for the atria to completely empty itself of blood into the ventricle before the ventricle sends everything ahead. Okay, we also don't want too much of a break in between. We don't want it to, the atria to contract and then the ventricle is kind of sitting and waiting on it, because that can cause what we call a block. But we'll get into those, I'm sure, at a different time. Okay, but the PR interval is another thing that we will pay attention to. And the last thing for the 5-step method of interpretation is the QRS complex. Okay, so how wide or narrow is that? Okay, a normal QRS complex will be anywhere greater than 0.12 seconds or greater than 120 milliseconds. Now, I do have a little note here, greater than 0.2 can be considered wide, and that does apply. Notice though the verbiage is greater than 0.12. So this is where greater EKG knowledge, when you're reading the actual 12-lead strip, not just our 4-lead strip, really comes into play. Wide complexes can indicate potential malfunction of the heart, or can kind of make a little murky our diagnosis of things like heart attacks or STEMIs, which is something we can see on a 12-lead EKG. You cannot diagnose any STEMIs on these 4-lead EKGs, okay? Now with the 4-lead EKG, I should have talked about this a little sooner. When you get these strips with that on there, there will be 4 boxes that will be filled. Lead 1, lead 2, lead 3, and AVR, okay? Now, because of this, the numbers there, kind of scrolling back to Einthoven's triangle here, we tend to use lead 2 to read all of our rhythms. And the reason we do so, as you can tell from this diagram, is that the negative to positive is always going to be the flow of electricity, and that includes the heart's electrical pattern. So normally, if you know the SA node to the AV node to the bundle of His to the Purkinje fibers, right? The electrical activity of the heart runs from patient's right to patient's left, okay? And so that's why we read this lead, because lead 2 runs electrically from patient's right to patient's left. So it kind of follows that along, and it just gives us the clearest view. Okay, so those are going to be the basics of just kind of EKG interpretation. That's just the tip of the iceberg when it comes to this, but it is a good starting spot. This is something, if you're interested in becoming a paramedic, becoming an EKG tech, maybe even med school, nursing, depending on the profession, this is something that you need to be familiar with. So this is not something that, if you're at the basic scope, will necessarily be tested on like the NREMT exam, but it is something just maybe to keep in mind. And maybe it'll help you as you're starting to figure out the electrical conduction of the heart anyway. It'll help you kind of figure out, okay, this is why they're looking at this is what they're seeing. And then it's something that you as a provider, if you're out in the field as an EMT basic, you're not going to necessarily be diagnosing, you're not going to be doing any of the grunt work with that, leave that to your paramedic, but there are things you can do to be helpful, right? If you put the 4-lead on somebody, which is in your scope to do, not read, but to put it on, you can feel a pulse and look at that monitor and say, yeah, okay, cool, they're lining up. I have a total of 85 beats, and my 85 beats that I'm feeling on the pulse are mechanically lined up with every electrical spike that I see there. Okay, so that's gonna be the basics. Do you have any questions, leave a comment, and we will get back to EKG stuff, hopefully in the future. Did I sound stupid?
Yes. One take wonder.